Hello everyone and welcome to our module on decision-making capacity. Decision-making capacity is defined as the ability to comprehend information about illness and treatment options and make choices in keeping with personal values, and it is usually discussed regarding a specific choice. For example, the patient has capacity to consent to surgery, or the patient has capacity to decline medical care. It is a key element of informed consent, which I discuss in another video, and it's also a key component of the ethical principle of autonomy. We always respect patients' autonomy, but we do so presuming that they have intact decision-making capacity. A related term to decision-making capacity is competency, in other words, whether a patient is competent or incompetent. And it's important that you understand that this is a legal judgment. Competency is different from decision-making capacity. It can only be determined by a court or a judge. Clinicians, on the other hand, can determine decision-making capacity. So this is especially important for your boards. If they give you a question and ask you whether or not the patient is competent, you need to understand that you cannot determine that. It needs to be determined by a court or a judge. There are four key elements to decision-making capacity, and I've listed them all on this slide. The first one is understanding. Patients need to understand their disease and the therapeutic options. Patients must express a choice. They need to clearly be able to communicate a yes or no. Patients must appreciate the facts. This is obviously related to understanding, but they need to appreciate how the disease and the therapy will affect them. And then finally, patients need to demonstrate reasoning. They need to be able to compare options and understand the consequences of one choice versus another. Other important elements of decision-making capacity are listed on this slide. To have decision-making capacity, patients must be greater than or equal to 18 years of age or legally emancipated. And I talk about emancipated minors in the video on informed consent. Also, their decisions must remain stable over time. If they keep changing their decision from one day to the next, this is a demonstration that they may not have decision-making capacity. Their decisions cannot be clouded by a mood disorder. So, for example, a patient who is depressed and suicidal and wants to decide to leave the hospital cannot do so because their decision is clouded by their depression. And then finally, they cannot have altered mental status. This means they cannot be intoxicated, delirious, or psychotic. So, for example, the patient who appears in the ER intoxicated and has a serious medical condition and wants to leave cannot leave because that patient does not have decision-making capacity. They have altered mental status related to alcohol intoxication. Let me briefly mention intellectual disability. This includes patients with Down syndrome or Fragile X syndrome or other forms of intellectual disability. You should be aware that this does not automatically preclude decision-making, and this often comes up in board exams. Disabled patients can still have decision-making capacity provided they meet the usual requirements. They need to understand, express a choice, appreciate the facts, and demonstrate reasoning. But there are many high-functioning patients with Down syndrome and other forms of intellectual disability, and if they meet the usual requirements, then they do have decision-making capacity. So for the rest of this video, I'm going to talk about how to proceed when patients lack capacity. And the way this usually comes up in board exam questions and also in real life is with an elderly patient with a chronic illness who becomes severely ill. So for example, if an elderly patient with advanced heart failure is admitted to the hospital and becomes severely ill and is on mechanical ventilation in the ICU, that patient will be incapacitated and unable to express choices about their care. So how are you going to make decisions for that patient who lacks capacity? And there are two main ways this is done. They are advance directives and surrogates, and we'll talk about these in the next few slides. So an advance directive is a set of instructions by the patient in case of loss of capacity. So patients create an advance directive when they are well, and it states what their wishes are if they lose capacity. And there are two main types of advance directives, the living will and the durable power of attorney for health care. A living will is a document that lists patient preferences for medical care, and it takes effect if the patient is terminally ill and incapacitated. And it usually addresses things like life support and critical care, and in many cases, it directs withholding of heroic measures. For example, patients will not want to be on life support in the ICU, and they will state this clearly in a living will, and that will tell you what to do when the patient becomes incapacitated. The second type of advance directive is called a durable power of attorney for healthcare. Many people just call it a power of attorney. It's also often called a healthcare proxy. This is a signed legal document by the patient that authorizes a specific surrogate to make medical decisions in the case of the patient becoming incapacitated. And the job of the surrogate, who is the healthcare proxy, is usually to follow the patient's wishes. In other words, to answer the question, what would the patient want if that patient becomes incapacitated? So for example, many husbands and wives will fill out a healthcare proxy indicating that their spouse is their power of attorney, and if their spouse is not available, it is one of their adult children. Now, what do you do if there is an absence of an advance directive? This often happens in real life. Patients become critically ill, and they did not leave instructions for what to do regarding their care. Some states in the U.S. recognize oral or spoken statements as evidence of an advance directive. These must be reliable and repeated statements by a patient about their wishes, and they usually need to be witnessed by several people. So the way this will appear, usually in a board question, is that a patient becomes incapacitated, but multiple different family members heard them say many times that they did not want to be on life support. Sometimes there will even be evidence that it was written down, and these can be relied upon as an advance directive in many cases. For incapacitated patients with no advance directive and no reliable repeated statements about their wishes, you can designate a surrogate. This is only done when there are no advance directives available and you need someone to make decisions because the patient has lost capacity. And the role of this surrogate, just like we discussed previously, is to determine what the patient wanted. And there's a standard hierarchy of how surrogates are determined if there is no power of attorney. The first option is the spouse. The second option is adult children. The third option is the parents. The fourth option is adult siblings. And the last option is other relatives. And this is the way things are often handled in real life in the ICU when patients are critically ill. The family is gathered together, and the spouse and the adult children together will make a decision about what the incapacitated patient would have wanted if they were able to speak for themselves. And the final topic I'll mention in this video is brain death. Brain death refers to the permanent absence of brain functions, and there are various clinical criteria by which you can declare a patient brain dead. And when a patient suffers brain death, they are considered legally dead in the United States. This means that life support may be withdrawn even over surrogate or family objections. So when a patient suffers brain death in the ICU, they may still have some vital functions because the ventilator is ventilating their lungs, and they may still have some contractions of their heart. In these cases, if the family wants to keep the patient alive, you do not have to do so. Care is basically considered futile, and the patient is considered legally dead. So normally we say that you should respect the autonomy of the surrogate or the family, and even if you disagree with them, you should do what they say. But brain death is an exception, and this often comes up in board exams. You do not have to keep patients alive with life support after they have suffered brain death. And that concludes our video on decision making.